now all you have to do is focus, listen, and ensure that our 200, our 15 to 20 questions which will be integrated with radiology are secured, or at least most of them in the next 2 hours, right? So I think that's a good deal. As far as the PDF is concerned, I've uploaded it on my group and channel. You can get it from there. Yeah, I will also the annotated PDF will be posted in app. All right, so you can check it under the notes section. Right. So now let's begin. No time to waste that we have. So let's quickly dive into it. It's going to be according to the system so that it's easier for you to revise. Okay. Group link group link and all आज छोड़ दो. Okay, no group links today. Let's just focus. अब एग्जाम आ रहा है, ग्रुप से कुछ नहीं होगा. No group is going to give you anything now. Just revise, just read what you have read. Okay, I am not sick. Thank you for asking. It's just cold out here. Okay, otherwise I'm all good. Thank you. I hope everybody is good too. Nobody is sick, and it's a happy new year for all of us. Okay, all right. Let's begin with GI and hepatobiliary radiology. So before we jump into the pathologies, a few normal investigations that I want to talk about. So साथ साथ revise करो, answer, active recall करो, and then it will be done. Okay. So look here, what do you see? Yes, what is this investigation? If I ask you, the options are CT enterography, barium meal follow through, or barium enteroclysis. What do you think is this investigation here? The first one. Oof, a lot of you saying CT enterography, which is breaking my heart on the new year. First thing, it is not a CT. On CT, we are going to see that the bones are white. It's a cross sectional investigation. When you see that it's an X ray, it is a barium investigation. Now, is it barium meal follow through, or barium enteroclysis? So, barium meal is only going to be stomach. Stomach is going to be focused, not the small intestine. So, it's not barium meal. Barium meal follow through and enteroclysis both see the small intestine. All right. So this is barium meal follow through, where the patient drinks the barium, and when the barium reaches the small intestine, I'm going to see that. Barium enteroclysis, on the other hand, we will have a tube. We will have a tube inserted till the DJ flexure, and I inject the barium so that the distension is better. Can you compare the loops here? Look at the jejunal loops in barium meal follow through and look at them in enteroclysis. The margins, the loops, the mucosa appear so much better because the distension is better, right? So that is what we have to understand here. Pehla step hai to identify barium image versus CT. Second step is to see whether it's BMFT or barium enteroclysis. I hope this is clear to all of you. So barium meal follow through is for the small intestine. Barium enteroclysis is also for the small intestine. Now in the small intestine, how to distinguish the bowel loops? So duodenum is easy because of the C loop orientation. C loop hai, we can identify. These loops are jejunum or ileum. How do we know? So we look at the feathery margin. You see the feathery margin? Look here, how beautifully here you can see the jejunal loops. Can you see how they have these folds? What are these folds? Called? These folds are what are called as valvulae conniventus or valves of Kirkring. Okay, valves of Kirkring. This is what we see in jejunum. Okay. I would advise all of you to, just focus on academics rather than video will remain, video will not remain. अभी आ गए हो यहाँ पे पढ़ लो है ना, just get it done with and finish it off. Why do you care for video being there later or not? Now that you have showed up, just finish it, right? That is the main purpose, that you clear the exam. बाकी सब चीजें तो secondary है ना. So content you are getting right now, just do that and finish it off. So barium enteroclysis, jejunal loops. All right, this is what you have to, barium enteroclysis versus barium meal follow through, small intestine. Jejunum, you are going to recognize with these complete mucosal folds. On the other hand, what you are seeing here in the pelvis are the ileal loops. The ileal loops are not going to have any folds. Now look at this image. Here we are seeing the colon. Colon का feature होता है that there are incomplete folds, which are known as hostrations. So colon, remember, are gonna have incomplete folds. So this is how you can distinguish small bowel from large bowel. Large bowel is peripheral, hostrations, colon, and this investigation becomes barium enema. ठीक है, तो ये हमारे बेसिक सॉर्टेड हो गए. वी गॉट जेजुनम, वी गॉट इलियम, वी गॉट कोलन. यू नो हाउ टू आइडेंटिफाई ईच ऑफ देम, यू नो हाउ टू आइडेंटिफाई बेरियम. टेल मी, इफ अ पेशेंट हैज परफोरेशन, कैन आई गिव बेरियम टू द पेशेंट? अगर उसको फ्री एयर है, एयर अंडर द डायफ्राम, कैन आई गिव बेरियम? नो, आई कैन नॉट गिव बेरियम. सो वन contraindication is perforation. If a patient has intestinal obstruction, can I give barium for the patient? Intestinal obstruction, no, I cannot give barium, because when I load an obstructed intestine with barium, it can perforate again. So these are contraindications of barium. So in these cases, one more contraindication, tracheoesophageal fistula. If I put barium, it will go into the trachea. I don't want to do that. So in all of these, tell me, can I use iodinated contrast media instead? Can I use iodinated contrast media? Is it safer? That's also contraindicated. That is safe. So iodinated contrast media is safe. इसमें आपको वो क्या लिख सकते हैं? They can write gastrographin, that is iodinated. They can write iohexol, that is iodinated. So all of these are safe. Okay, so this is what you have to understand here about the basics of barium. ठीक है. With this thought only, now look at these two x-rays. What you see is distended bowel loops. If I give you the history, patient has pain abdomen, patient has vomiting, obstipation, basic diagnosis क्या बना? Obstruction, intestinal obstruction. Now the question will be, one of these x-rays, tell me whether it is small bowel obstruction or large bowel obstruction. So let's look at first one. क्या दिख रहा है? Step ladder. Okay, you are seeing the captions, right? Let me get that removed. So admin, can you just close the captions from Zoom? Zoom से captions हटा सकते हैं? तो YouTube पे स्ट्रीम नहीं होगा, राइट? तो ये एक बार देख लेना. ओके, सो एनीवेज, सो दिस इज द स्टेप. तब तक एडजस्ट करो जब तक है, वी विल गेट देम रिमूव्ड. ऑलराइट, सो दिस इज द स्टेप लैडर पैटर्न, which is the multiple air fluid levels that you are seeing here, and that is small bowel obstruction. And another thing we have just discussed, what do you see in the loops? If I ask you, ये jejunum है, duodenum है, ileum है, colon है, can you tell me? Yes, we are seeing that इसमें ये complete folds है, isn't it? So this is valvulae conniventus. So valvulae conniventus, I can say that these are jejunal loops which are dilated. So once a question has come in FMGE that this particular case, is this proximal small bowel obstruction or distal small bowel obstruction? What will your answer be now? Small bowel तक तो पहुंच गए, अब proximal है या फिर distal है? So only jejunum is dilated, isn't it? Ileal loops in the pelvis are not dilated at all. I am not seeing any dilated bowel loop here. So this means that only jejunum is dilated. Ileum is not dilated. So it is proximal. So this is proximal small bowel obstruction. But if jejunum plus ileal loops are dilated, both are dilated, that means obstruction is somewhere here, distal to the ileum. तो उसको बोलेंगे distal small bowel obstruction. Did you guys understand this? Proximal versus distal small bowel obstruction? All right. So compared to that, now here I am seeing that a peripheral bowel loop is dilated. And look, can you appreciate the folds now? जो हमने अभी discuss करा. There are folds, but they are incomplete folds. So ये क्या बना? This is hostrations, and that is why this is going to be large bowel obstruction. Which is more common? Small bowel obstruction is far more common than large bowel obstruction, because the most common cause of small bowel obstruction is adhesions. Adhesions कैसे बनते हैं? There will be some sort of history of prior surgery. Some prior surgery led to adhesions formation, which led to small bowel obstruction. So logically speaking, how will I manage it? Is there a surgical management we do or conservative management? Obviously conservative, because surgery के कारण से हुआ है. It is because of the surgery. Now if I keep doing a surgery to operate it, it's a vicious cycle we are setting, right? So we don't want to operate this. The management here is going to be Conservative, right? So conservative management, you keep the patient nil per oral, put an NG tube, give IV fluids. तो अपने आप ठीक हो जाएगा. In a matter of around 24 hours, most will resolve. If it doesn't resolve, then we have to go for surgery. On the other hand, large bowel obstruction, the most common cause here is CA, carcinoma of the rectum, of the rectosigmoid junction. Do you think I can do conservative management there? I can't, right? Because then the cancer will not go away. We tell the patient 24 घंटे रुको, cancer ठीक हो जाएगा. That is not fair, right? So remember, here the management is going to be urgent surgery. All right. So this is what you have to understand as far as SBO and LBO is concerned. Right. Now looking at the pathologies. So three pathologies now for barium. I am showing you three barium swallows. Very quickly, I am sure all of you know, when you see one smooth tapering, कहाँ पे देखना है? यहाँ पे. The stricture has smooth margins. This is what we call as the bird beak sign. Smooth मतलब benign. So this is achalasia cardia. Achalasia cardia is a defect in the lower esophageal sphincter. It is so tightly packed, it is not relaxing. वो relax नहीं करता, so it's a stricture. It's a functional stricture. Achalasia is a motility disorder. So motility disorder के लिए investigation of choice क्या होगा? Merce motility, Merce manometry. Anybody can tell me classification that we follow on manometry for motility disorders? Chicago classification, right? So this is what you need to know for achalasia. On the other hand, ye stricture dekho, you are seeing very irregular outpouching, you are seeing this shouldering here. So what is this? This is a malignancy. Malignancy is going to be irregular, right? So this is the rat tail sign that you see, which is seen in CA esophagus. Any malignancy, we will have to biopsy to prove that it's a malignancy. Esophagus biopsy kaise karenge? By an endoscopy. So the investigation of choice for this condition, or if they ask you what will be the next step, what will you answer? You will do an upper GI endoscopy and you see the mass and you biopsy it, right? But अगर आपको पूछते हैं staging, what is the best to stage it? तो TNM staging होता है for T, which is the tumor depth, and the nodes. What is the best investigation? It is endoscopic ultrasound. Same endoscope, now we connect a probe. We see how deep the tumor is going, whether there are nodes or not. But agar M stage, any cancer in the body, metastatic workup के लिए investigation of choice कौन है? PET CT. Yeah, so this will cover all of our questions on CA esophagus. Understanding everybody, speed thoda fast hi rahega because we want to cover more ground in 2 hours. Okay, so this is achalasia versus CA esophagus. Last thing, what are you seeing here? I'm seeing that the esophagus looks like a corkscrew. So this has been asked a lot of times in FMG. So ye hai corkscrew esophagus, and corkscrew esophagus is indicating what? Diffuse esophageal spasm. The esophagus is undergoing spasmodic contraction. So इसमें patient कैसे आएगा? The patient is going to present with retrosternal chest pain. It can actually mimic MI, right? It can mimic myocardial infarction also. So this is what you have to understand here, that this is diffuse esophageal spasm. Again, a motility disorder. Investigation of choice remains manometry. Okay, so this is about the three bariums that we need to know. Moving on to two pediatric conditions. First one is a newborn baby who's having one of you is asking difference between diffuse esophageal spasm and nutcracker. So nutcracker esophagus is where you have very high amplitude contractions. All right. So radiologically, it has no counterpart. So it will not be asked to you as a radio image, right? So it has no radiological sign. It's just a very high amplitude contraction which happens. It's a manometric diagnosis, right? Okay. So coming back here, we are having a newborn with respiratory distress, and very nice. All of you are answering. I am seeing that the bowel loops have herniated. कौन सा side है, right या left? Bowel loops have herniated on what side? So we always see the pointer. अगर लिखा है तो बहुत बढ़िया, अगर नहीं लिखा, always opposite. Somebody standing opposite to me, उसका क्या right left है? वही X-ray का right left है. So this is right, this is left here. So whenever you see left-sided hernia, congenital diaphragmatic hernia, which is what type? You remember BPL. Left side posterior defect, this is Bochdelex hernia. So we have two types of congenital diaphragmatic hernias. Bochdelic on the left side, Whereas if it is on the right side through an anterior defect, उसको बोलते हैं morgagni, and this is something which presents very late in adults, because right anterior you only have the liver, so liver comes up a little bit, doesn't really cause a lot of damage. It is this hernia, Bogdalek hernia, which is going to present in neonates with respiratory distress. So they will give you this history. Now you can have three questions which can be asked here. The first question we have done is the diagnosis. ये आपने कर लिया. Second question will be what is contraindicated in this baby. इस बेबी में आप क्या नहीं करोगे. This baby has respiratory distress. Every baby with respiratory distress will get a positive pressure ventilation or a bag mask ventilation. But this baby, I can't do bag and mask ventilation because that air will go further into the intestine and it will inflate, causing further lung hypoplasia. राइट. सो इससे हमने एक और क्वेश्चन आंसर कर लिया था. नेक्स्ट क्वेश्चन दैट इज व्हाट इज द मोस्ट इंपॉर्टेंट प्रोग्नोस्टिक फैक्टर हियर. So see what is happening to this baby. Bowel loops have come in the left side. Because of this, the heart which was on the left side has displaced to the right side. So the baby ends up having no lungs to breathe, right? So the most important prognostic factor here is pulmonary hypoplasia, right? The next question, what will be your next step for this baby? This baby can't breathe. So sabse pehle airway, right? I got to give the baby oxygen. So first step is ET tube. Any other tube that we want to put? I want to put an NG tube, nasogastric tube also. Can you see in this X-ray, guys, कि एक white line है, this is ET tube. एक और white line है जो ऐसे जा रहा है. What is this? This is the NG tube. In a normal person, this NG tube should go here, है ना, stomach में जाना चाहिए. But in this, because the stomach has herniated up, the NG tube points here. So my NG tube serves two purposes. One, it confirms the diagnosis, and second, it also decompresses the bowel loop. Bowel loop decompress हो जाएंगे, छोटे हो जाएंगे, more lung will inflate, right? So this is what is my next step, and eventually what is the definitive management is surgery, right? So after securing airway, after putting NG tube, the baby goes for surgical repair. So this in a nutshell covers our entire diaphragmatic hernia. Okay, everybody, are we good? याद आ रहा है सब कुछ? Next, we are going on to another condition where they will give you that a patient underwent rotavirus vaccination, and now the baby, 6-month baby, is complaining of intense pain. Baby is crying incessantly. What is your diagnosis? So the moment you hear कि बेबी को क्या मिला है, रोटावायरस वैक्सीन, what will you think of? Very nice. You are gonna think of intersusception. Very very important buzzword. ठीक है. So intersusception मतलब one bowel going into the other. So यहाँ पे आपको क्या दिखेगा? First of all, the question will be what is your next investigation? Next investigation or my first investigation is going to be ultrasound. Does ultrasound have radiation? Ultrasound has no radiation. Which other investigation has no radiation? MRI, है ना. So routinely 4 investigation: X-ray, CT, ultrasound, MRI. X-ray, CT have radiation. MRI, ultrasound have no radiation. So ultrasound is something that I will prefer in children always as the first investigation, right? So if you don't know answer, think in these lines, okay? So concept strong honge, we will be able to take good guesses. So this is ultrasound. I did the ultrasound. What do I see? Can you see how it looks like a donut? There is one bowel and then there is another bowel within it. So donut sign, target sign, sandwich sign, बहुत सारे नाम है. Ultimately, I have to see one bowel inside the other. तो ये देख लिया. So now my confidence is increased that it is indeed intersusception. So now what is my investigation of choice, or what is my best investigation, or what is my gold standard? Because in this case, it doesn't just confirm the diagnosis, it is also therapeutic. That is why I am using this term. ये gold standard term is only used when something can treat also. Diagnose करने गए साथ साथ treat भी कर दिया. So gold standard. So what is that? That is going to be our barium enema. Didn't I just tell you कि कभी भी obstruction हो, we can't give barium. Then how am I giving barium here? Ever wondered कि मैम obstruction में तो barium contraindicated था. So here, am I doing a barium meal follow through? क्या हम आगे से जा रहे हैं? No, we are actually coming from the rectum. We are coming from the distal margin. Why am I giving the barium? I am giving the barium. Let's say यहाँ पे there is the intersusception. The bowel has come inside from here. So what will happen when I inject the barium? It is gonna push, right? It creates this hydrostatic pressure. So what will happen? This slowly, this bowel loop which is intersuscepted is going to come out. So two things I see here. We see a claw sign and we see a coiled spring sign when it starts to come out. So two signs, claw sign and coiled spring sign on barium enema. Instead of barium enema, can I do air enema? Yes, inject whatever. Ultimately, bahar उसको push करना है. You can inject air also, you can inject saline also. Most commonly, we do a barium enema, right? So this is what you have to understand about intersusception. All right, yeah. Chalo, moving on to the most important question. You can't get this wrong. You have a young male with severe pain abdomen. So the moment you see कि किसी को पेट में बहुत दर्द, and what X-ray are you seeing? Chest X-ray. Pain abdomen, but chest X-ray given. Directly, where will you look? You will directly look under the right diaphragm. When you start to see that there is black air, what is your diagnosis? My diagnosis becomes pneumoperitoneum. There is a perforation which has happened, perforation of hollow viscus. So perforation peritonitis, pneumoperitoneum. Can I look here, guys, under the left diaphragm to make a diagnosis of pneumo? Never, because then every diagnosis you make will be pneumo only. Why? Because यहाँ पे हमारे पास है stomach. So I never look here. Here we have the fundus, right? Fundus air. Normally हम सब में present है. So what we want to see is the right air under the diaphragm. Okay, so this is what you have to understand. Plus they are giving us history कि उसको radius fracture था, for which he's been taking a lot of painkillers. Is this relevant? इस history का कोई importance है? Importance है because he would be taking NSAIDs. NSAIDs can cause gastric ulcer. Gastric ulcer can perforate, right? So duodenal ulcer, gastric ulcer, it can perforate it. So they have given us the background also. Now the real thing. So diagnosis to bana liya, but they're not asking that. They are asking what is the next step. So we will never jump to answer. I will evaluate over all four options and only then I will mark it. This is the most important thing you remember on 20th of Jan. That you read all four options. Don't jump to answer. वरना जो हम silly mistakes बोलते हैं वो हो जाते हैं. And those silly mistakes are not silly. They are the difference between 145 and 155, which is a very big difference, right? So you have to avoid these silly mistakes. You have to read all four options. There is just no other way. Okay. So this is one promise you will all keep right now. You will all make a promise to me that, ma'am, irrespective of what happens, we will read four options. It will not take up your time. We will read all four options and we will eliminate. How will you approach every 300 MCQs? You will read ये नहीं है, ये नहीं है, ये नहीं है. This is the answer. It will not take up time. I tell you that don't worry about time now. You will be able to manage time, but you will not make silly mistakes. Okay, right. So coming back to the question now, advise him to stop painkillers कि कोई बात नहीं, अभी perforation हो गया, आगे से मत खाना. No, this is clearly not the answer. E fast. T stands for trauma. There is no role of trauma here. There is no trauma that this patient has. Barium meal in perforation. Should I do barium in a patient of perforation? Contraindicated. I should never give barium. So ultimately my answer becomes exploratory laparotomy. So this is a surgical emergency. You directly go for exploratory laparotomy. But what if I give you an option of IV fluids and the question is asking me next step? Then IV fluids becomes better answer, right? So that's the importance of reading the options. आपने ये याद करके गए थे कि भाई PYQ में exploratory laparotomy था, यही मार दो. And you don't see that IV fluids is sitting there. So if IV fluids is there, that is your better answer. First resuscitate, then take the patient up for surgery. Understood this? So this is what you have to remember. This is a surgical emergency. First resuscitate and then operate. Okay, no other investigation to be done. Right, 4 signs, straightforward questions. What do you see here? So उससे पहले मुझे ये बताओ, what are these bowel loops? If I ask you, what must be these bowel loops? Again, it's a barium investigation. No snowman. Again, in radiology, if you look for a sign, you will see it. अगर snowman ढूंढने गए तो कहीं ना कहीं बना ही लोगे यार, snowman की आंखें तो दिख रही हैं. snowman must be close, ये उसका nose होगा. तो बनाने को तो मैं कहीं पे भी कुछ भी बना सकती हूँ in radiology, right? So never look for a sign, look for the pattern. That is why you would never see me teaching signs. Yeah, I will tell you the name, but that is never the approach. The approach is always the pattern. Okay, right. So all of you are correct. This is indeed the jejunal loops because they are feathery. These are the iliac loops, and look here. This is the ileocecal junction. This is where the terminal ilium is meeting the cecum, and that is where I see a narrowing. It's become thin like a string. So this is what we call as the string sign. This can be seen in tuberculosis also, where there is terminal ileal stricture, and it can also be seen in Crohn's disease, where terminal ileum is the most common site. Crohn's के लिए particularly we have given a name, string sign of Cantor. Cause Crohn's, cause Cantor. That's how you remember it. Okay, so this is terminal ileum stricture, string sign. Similar string sign can also be seen in CHPS. If you see that the stomach is distended and then you see a string forming like this is the pylorus, which is stenosed, which is narrowed. Yeah, so this can also be seen there. इसीलिए साइन का कुछ मतलब इंपॉर्टेंस नहीं है. यू शुड नो बट स्ट्रक्चर है. wherever there is a structure, it looks like a string. Yeah, so that is what you have to remember. Next, what do you see in this? I am seeing that there is a continuous involvement of the colon, right? So starts from the rectum and goes continuously, and the hostrations we had learned are lost. There are no hostrations. It's solid like a lead pipe. So this is the lead pipe colon, which is seen in ulcerative colitis. Ulcerative colitis is continuous involvement, superficial involvement. On the other hand, Crohn's disease is skip lesions, transmural involvement. Yes, ये सब याद है. Crohn's versus ulcerative colitis. So lead pipe is going to be ulcerative colitis, where there is a continuous involvement. Most common site is rectum. Yeah. All right. ये क्या है? बहुत ही baby sign. When you see something is very irregular, like an apple which has been eaten up. This is the apple core sign that we see in a malignancy. Anything irregular like this has to be malignancy. Apple core, CA colon. And what do you see here? We are seeing that from the sigmoid colon, there are these outpouchings which are there. Very nice, like a sawtooth. So this is the sawtooth sign that you see when there are diverticules. So this is sigmoid diverticulosis, and this is what presents with painless lower GI bleed. So इसका presentation होगा painless lower GI bleed. Okay, so this is sigmoid diverticulosis. But अगर तो पेशेंट कह रहा है कि मुझे पेन है, लेफ्ट लोअर क्वाड्रेंट में फीवर है, ल्यूकोसाइटोसिस है, देन दिस हैज बिकम कॉम्प्लिकेटेड टू आइटिस, है ना, वो बन गया है डाइवर्टिक्यूलाइटिस. इफ देयर इज डाइवर्टिक्यूलाइटिस, कैन आई गिव बेरियम? Inflammation, I can't give barium, it will perforate. So in this case, the investigation of choice becomes a CT scan, non-invasive, contrast enhanced CT scan. Okay, so this is about diverticulitis. Thoda surgery question. There is a Hinchey classification for diverticulitis that we have to know about. Just the name is enough. Okay, done. Going on to liver, what do you see here in the liver? I am seeing that there are multifocal cysts. Then, so there are 3 images that can be asked for the same condition, which is hydatid cyst. So what you see here is this honeycomb appearance. Multiple daughter cysts are there. When it degenerates, what will happen? We will see that there is this floating membrane. All right. No, no, no. Diverticulosis is not in children. It is an elderly population. All right. So elderly, chronic constipation, they will have. Okay. Right. So this is honeycomb. This is water lily. Okay. So water lily sign, where you see that the membrane has degenerated and it's floating. And this is the end stage. ये investigation बताओ. CT, NCCT, CCT, MRI और X-ray. बोन वाइट है तो सब लोग सीटी तक पहुंच गए. या अब बताओ, एनसी, नॉन कॉन्ट्रास्ट और कॉन्ट्रास्ट What will you look for? I will look for this vessel anterior to vertebrae. If that is white, it is contrast enhanced. If that matches the muscle behind the spine, it is non-contrast. So this is aorta here. If aorta is not whiter than the muscle, means it is a non-contrast CT. If aorta is whiter than muscle, it is contrast enhanced CT. Okay, so we've done an NCCT where I see something white in the liver. Yeah, right side hai, liver hai, white like the bone. So this is what calcification looks like. So this is our calcified hydatid cyst. ठीक है, this is the end stage, doesn't need any treatment. Every other patient, honeycomb, water lily, we will treat the patient with albendazole. So drug of choice, albendazole. What is the causative agent? Hydatid cyst is caused by Echinococcus granulosus. The primary host is dog. Humans are end stage or dead end host. We don't transmit it anywhere. We are accidental hosts. Okay, so this is what you have to remember here. Talking about 4 gallbladder pathologies, remember the investigation of choice for all things in gallbladder is always going to be ultrasound. No doubts there. Now when I see something white and uske पीछे क्या दिख रहा है? Shadow. Yes, posterior acoustic shadowing. This is a calculus. So cholelithiasis, gallbladder calculus, investigation of choice, ultrasound. If there is inflammation, cholecystitis, this is what is again going to be ultrasound. What about this? I am seeing that there is an echogenic lesion here and you are seeing that there is no shadowing. What is this? This is a gallbladder polyp, है ना? So hang कर रहा है, there is no shadowing, GB polyp. What do you see here? I am seeing that छोटा comet tails are forming. So just the sign we need to remember, comet tail sign seen in adenomyomatosis of the gallbladder. Yeah, and this question came in NEET, so it may come. अभी तक FMG में पूछा नहीं है, but if this question comes, I will take party from all of you. Okay, so what are we seeing here? We are seeing that there is a cap, right? The GB looks like it's folded upon itself. Very nice. A lot of you giving me the answer. So this is a Phrygian cap. What is the significance? आप पेशेंट को बोल रहे हो आपको फ्रिजियन कैप है, पेशेंट बेचारा डर गया कि मैं मरने वाला हूँ. व्हाट विल यू टेल हिम? टेल यू नथिंग, इट्स अ नॉर्मल एनाटॉमिकल वेरिएंट, है ना, कुछ नहीं करना. सो दिस इज अ एनाटॉमिकल variant. All right, so this is about the 4 GB images that can come to you in the exam. All right, moving on to obstructive jaundice. So GB is different, always answer is ultrasound, but when it comes to CBD stones, when it comes to CBD pathologies, ultrasound is not useful to us. It will only show us कि भाई CBD is dilated, but what is the cause? It cannot tell us. So for that, investigation of choice becomes MRCP. It's an MRI investigation, MR cholangiopancreaticography. So when I do MRCP, look at this. The stone appears black like this. So we made the diagnosis that there is a distal CBD stone, that there is choledocholithiasis. Now you will ask me, ma'am, what next? How should I treat this patient of CBD stone? For that, you will tell ki, ma'am, gold standard, diagnosis confirm plus therapeutic is this investigation, which is, yes, ERCP. How did you identify it? You identified it because there is one endoscope that you are seeing. You are identifying because X-ray is there in the background. There is going to be contrast, isn't it? So this is what is your ERCP. Formica nail is one. Dormia basket, right? So Dormia basket can be used to retrieve stones. Yes, we can use it for CBD stones. We can use it for ureteric stones. Yeah. So Dormia basket can be used to remove, but ERCP, basically the idea is that I can remove these stones also. We've gone in with an endoscope. All right. So this is what you need to remember about CBD stones. That MRCP hota hai, ERCP hota hai. Ultrasound is only used as a preliminary investigation. It is not the best investigation. Okay. Understood this? Last spotter for hepatobiliary, what are you seeing? I am seeing that there are multifocal strictures, beaded sort of appearance. Very good. Beaded sort of appearance. This is PSC, primary sclerosing cholangitis. Associated with what? What condition this would be with, this would be associated with ulcerative colitis more than Crohn's, right? So IBD के साथ associated होता है, and this is a pre-malignant condition, can also lead to cholangiocarcinoma. All right. Okay, next. No, there is no size limit for Dormia basket ureteric stone. Basically, any ureteric stone can be, anything more than 5 mm, we will use a ureteroscopy to remove it. Okay. All right. Next. What confusion in MRCP, ERCP, Ash? What is the confusion? All right. Moving on to GU, radiology. So here, two things that we need to remember. So what is the first image here? एंड में क्या फर्क होता है ओके सो इतना डिटेल्ड आई विल आंसर इन द एंड ऑलराइट सो वी वांट टू फिनिश द रिवीजन अ बिट क्विकली हियर डिटेल्ड अगर एक first time we are studying radiology this might be a bit quick so in the end I may answer all right so what you are seeing here there is distal ureter ka cystic dilatation okay so cystic dilatation of the distal end of ureter this is cobra head or adder head sign. So cobra head, adder head, this is ureterocele. Okay, ureterocele. Fine. What are we seeing here in this case? ऐसा लग रहा है नीचे से inferior poles are trying to meet and shake hands, isn't it? So this is what is called as shaking hand calluses or flower vase भी नाम दिया है and this image has come in a lot of exams. Basically ये किस में मिलता है? This is seen when the inferior poles of the two kidneys are fused. That is why they are meeting in the midline. Very nice. So this is horseshoe kidney. So horseshoe kidney ऐसा CT देंगे. Now tell me, is this NCCT or CCT or MRI or X-ray? Bone is white, so it's a CT scan. Now tell me NC है या C? Very good. अब दिख रहा है aorta. So aorta here is white. So this is a contrast enhanced CT. You can also see the kidneys. Kidneys अगर white है, it is a contrast enhanced CT. If I ask you what is this vessel here, जो मैंने red से बनाया, which is not very white, it is the vein, right? So कौन सी vein होती है right side of aorta? It is IVC. So IVC can be pointed or aorta can be pointed to you. Okay, but if I ask you ये छोटू सा vessel कौन है which is seen in relation to the isthmus which actually stops the kidney from coming up, it is not SMA, it is IMA, remember. So what happens, this kidney forms in the pelvis, right? All of us kidneys form in the pelvis and then they come up. But this horseshoe structure, when it's coming up, the ventral branch of aorta, which is IMA, will stop it from coming upwards. And that is why I will always see कि जहाँ isthmus है, उसके आगे inferior mesenteric artery है. Did you understand this, everybody? So this is IMA here that has been pointed. And a horseshoe kidney. You guys understood? Will you identify horseshoe kidney on CT? Will you identify IMA? Will you identify IVC aorta? Will you identify CCT? Very good. Okay. Next 4 images जो बहुत बहुत ज़्यादा आ रही है आजकल. So what do you see here? If I tell you there is a person who has very high frequency of urination. When I see the urine analysis, there is sterile pyuria. मतलब पस आ रहा है but no bacteria. It means it is GU tuberculosis, kidney tuberculosis, and this calcified kidney, white calcium, looks like cement से भरा हुआ. This is putty kidney. Very good. Completely calcified. Next X-ray, I see white है, but is it putty kidney? No, it is not kidney. It is the collecting system where there is a stone. Very nice. So this is staghorn calculus. Yeah, so this is staghorn calculus. Now look at the next one. Next one I see that, oh, अब तो ये bilateral है. Is it putty kidney? No, it is not putty kidney. Can putty kidney be bilateral? Never. Putty kidney is a non-functional kidney. It can never be bilateral. It is always unilateral because we can't live with two non-functioning kidneys. So when I see a bilateral involvement and I see that there is this calcium which is in the cortex or the medulla, what do you think? Medullary pyramids के shape का है या फिर cortex के shape का है? Looking like pyramids, no? So this is your medullary nephrocalcinosis. It's a systemic condition that you are seeing here. It is not polycystic kidney disease. A majority of you are saying polycystic kidney disease. Okay, see, polycystic, जब kidney में cyst है, are they white on X-ray? Are those cysts calcified? No, they are not calcified. The polycystic kidney disease on a normal X-ray, will I ever see as white white? No, I will never see that as white white. I will see an ultrasound where they're showing me black colored cysts. Remember that. Cyst is pani. Pani is not calcium. Understanding? कभी भी पानी देखना है, what will you do? Ultrasound. Anything fluid, anything cystic, ultrasound. That is what we have to remember. ठीक है, तो एक्सरे पे पीसीकेडी डायग्नोसिस नहीं बनाना. All right. So this is medullary nephrocalcinosis. कॉर्टिकल कैसा लगेगा? कॉर्टिकल में जस्ट कॉर्टेक्स पे देर आर गोना बी दीज स्पॉटी स्पॉटी calcification. This is how cortical nephrocalcinosis will look. ठीक है, आ गया समझ में? So this is going to be bilateral. It is associated with hypercalcemia. Any cause hyper PTH will cause hypercalcemia. ओके, ऑन दी अदर हैंड इफ आई टेल यू कि ये आईवीपी है, इंट्रावीनस पाइलोग्राफी है, एंड यू आर सीइंग दैट द किडनी इज नॉट एबल टू एक्सक्रीट कॉन्ट्रास्ट, इट इज swollen at the level of pelvis and ureter, it is not getting the contrast. Go, very good. This is PUJO, pelviureteric junction obstruction. So junction of the pelvis and the ureter is obstructed here. Yeah, meet. So medullary sponge kidney is also a differential of medullary nephrocalcinosis. Yeah, so it can be seen with hypercalcemia, medullary sponge kidney as well. So ये 4 DD समझ में आ गया. If it is only X-ray, something white is calcium. So unilateral, putty kidney. Shape of collecting system, staghorn. Bilateral, nephrocalcinosis. But अगर IVP दिखाया है and you see that oh kidney swollen है and contrast is not going into ureter, it is being retained, it is dilated, it is obstruction at this level. PUJO. आ गया समझ में फिर से? All right, so this is what you need to remember here. Next, investigation बताओ क्या है? This is normal. In the exam, the pics will be this clear. There is no way to know. But does that mean I should teach you from non-clear images? Obviously not, right? So you learn from the most clear images, have a clear idea, and then just pray that the images are clear in the exam, right? Something we can't control. So what do you have? We see the bladder and we see that this is the urethra. So this is MCU, micturating cystourethrophy. Okay, so this is where most of you are confused. Some people are saying IVP, some people are saying RGU, some people are saying BCU. So it is not BCU, first of all. There is no investigation like that. IVP, RGU, MCU. What is it out of these three? So MCU is micturating cystourethrophy. Means the person is passing urine and you are seeing that the bladder and the urethra is filled with contrast. So this is what MCU will look like. IVP will look like this, where they give you the kidneys में से contrast getting excreted and coming into the ureter, right? So the IVP is the only thing where I'm going to see kidneys. RGU, retrograde urethrophy. I will only see urethra here. I will see something like this, okay? Something like this. Only urethra will be seen, okay? So when you see bladder, cysto, it is C. I hope this is clear. Ab MCU is investigation of choice for two conditions. MCU में 3 लेटर, IOC में 3 लेटर, IVP RGU में भी 3 लेटर, but ये तो condition में भी 3 लेटर. So first condition is VUR, second condition is PUV. So if they give you there is a child who is having recurrent infections, मैंने MCU करा and look at what I'm seeing. I am seeing that contrast, instead of going down in the urethra, is going up into the kidneys. Yeah. So what is this? This is reflux, vesico-ureteric reflux. Contrast is going from the bladder into the ureter. Understood this, everybody? If IVP or X-ray is not set, then how to make difference? See, no? If this is the picture, this is IVP. If this is the picture where you see bladder and urethra, it is MCU. If you see just the urethra, it is RGU. Okay, right? Okay, coming back. So this is VUR where you see MCU will be given. That MCU is given and you are seeing that contrast going into kidney. This is reflux. When you see that there is a child who is having obstruction, child has having dribbling of urine. What is this? I see that suddenly after the bladder and posterior urethra, there is an obstruction. The contrast stream is very thin. It is because of valves here. So this is posterior urethral valves. Okay. Dr. Vishal, in the kidney wala X-ray, it will be mentioned. Like how I have given you that this is IVP, they will give you IVP. That's why I categorically said कि ये 3 X-ray है और ये IVP है. Understood? So coming back. So PUV on the ultrasound, can you look at this sign here? You see that this is the bladder and this is the posterior urethra. This forms a keyhole sign. Okay, so this is keyhole sign. All right. So this is what you need to remember as far as this is concerned. All right. Next. Yeah, so good question, how to distinguish between IVP and VUR. So that's why I said इसमें आपको दिया होगा कि एक बच्चे का MCU करा है. We have done MCU and this is the picture. So there they will definitely give you if they are showing VUR. Okay? Right. चलो गाइनी ऑब्स में चलते हैं, बहुत इंपॉर्टेंट. If I tell you there is history of amenorrhea, hyperemesis here, and this is the ultrasound. So I was expecting to see a baby on the ultrasound when female is 14 weeks pregnant. But what I see are these grapes. I'm seeing cysts. So this is a molar pregnancy, right? So this looks like hydatidiform mole. Remember hydatid, we saw the snowstorm appearance, honeycomb appearance. वैसा ही लग रहा है, इसीलिए उन्होंने नाम दे दिया hydatidiform mole. So this is a molar pregnancy. If I ask you what is your next step, what will you answer? Next step is suction and evacuation, right? So how do you treat this? Suction and evacuation. If I give you DNC as the option, will you mark it? Dilatation and curettage kar de? No. Why not? It is not done because it has risk of what? Very nice. It has risk of adhesion formation, which is called Asherman syndrome. Asherman syndrome में मेनोरेजिया होता है या ओलिगोमेनोरिया और हाइपोमेनोरिया और एमेनोरिया होता है. There is going to be reduced bleeding, right? So either oligomenorrhea, rarely it can also lead to amenorrhea, right? So risk of Asherman's, which is intrauterine synec, we don't do a curettage, all right? So suction and evacuation is what is done here. Okay, going on to bulky ovaries. All right, so how to know whether it is partial mole or complete mole? So partial mole will also have fetal parts. Do you see any fetal parts here? Fetal skull, fetal head? Nothing. All I see is grapes. So if it is partial, you will see fetal parts. If it's just grapes like this case will be complete molar pregnancy. ठीक है? दोनों में ही snowstorm मिलेगा, but in this you will also see some fetal parts plus grapes. इसमें खाली grapes, only complete. All right? That's how. चलो अब चलते हैं into two bulky ovaries. So if I give you this history कि patient is on IVF treatment and the ovaries are so bulky, what is your diagnosis? A. PCOD, B. OHSS, C. thecal lutein cyst, D. both B and C. आंसर बताओ क्या होगा? Okay, so a lot of you saying both B and C. अगर history of IVF treatment है, then it is only OHSS, na? So let me explain. Yeah, it was a trick question. So if I ask you कि this appearance, this radiological appearance can be seen in, then your answer will be both B and C. Understanding कि ऐसा large follicles, bulky ovaries is something that I will see in both OHSS as well as thecal lutein cyst. But the history will differentiate them. If the history is of IVF, it has to be ovarian hyperstimulation syndrome. If the history is of a molar pregnancy where you have too much beta HCG formation, then they are thecal lutein cysts. Yeah, फिर वो thecal lutein cysts बन जाएंगी where the beta HCG is stimulating the ovaries. So pathophysiology is the same, radiology appearance is the same, but clinically your history is what will decide what it is. आया समझ में सबको? Yeah, so this is what you need to remember. How will fetal parts be seen? Bones and all will be seen. Wait, can you see fetus here? Huh? So you see the fetal eyes, you see fetal bones. Nah? Look at this. These are two chota chota fetuses. So you know, you will get to know. They'll not ask you partial mole, first of all. They'll not ask you partial versus complete. It has never been asked, but even if they do, you'll see some sort of bony parts. Okay? ठीक है? Chalo. So this is OHSS and thecal lutein cyst. Now look here, if a female comes to you that there is irregular menstrual cycles, ये देखो अभी कोलकाता से आया मेरा दोस्त, look at this. So what is this here is, why such a specific name you have put? Who is that special friend who's come from Kolkata? I really want to know. All right, now what is this? There are peripheral cysts. All right, so there are peripheral cysts that you are seeing here. This is like necklace of pearl. So this is how you can distinguish these two. यहाँ पे बड़े बड़े cysts है, whereas here there are these small cysts which are arranged in the periphery. So this is your string of pearls, necklace of pearls, whatever you want to do with pearls. This is what it is. छोटे छोटे cysts मिलेंगे, छोटे follicles, small multiple follicles. You don't have to remember the size, the criteria keeps changing, so what you have to remember is that there are going to be multiple small cysts, string of pearls. The clinical criteria to diagnose PCOD, I am sure all of you know. So here we are talking about polycystic ovarian disease. It is the Rotterdam criteria, where radiologically you see string of pearls, clinically you have oligomenorrhea, hirsutism, and biochemically you see that the LH by FSH is raised, testosterone levels are raised. So this is what you have to remember for PCOD. All right, moving on to two kinds of twins. If you see that the wall between the two babies here is very thick and it is diverging to form this lambda here. So lambda sign, or you can also call it a twin peak sign. So a thick membrane means everything is separate. Dichorionic, diamniotic. They have their own chorion, their own amnion. Very independent babies, thick membrane. But if I see that between the two membranes, between the two babies, the membrane is very thin, inserting like a T. So T sign is monochorionic diamniotic, right? So monochorionic diamniotic anomaly to be picked up in a child, the most severe anomaly where there is no brain. The brain is absent, dysplastic. What is this? Is it stuck? No. Is it stuck? I think it's okay. Yeah. So this is anencephaly. Anencephaly, this is where the brain is absent. It is dysplastic. Yeah. So you can see on a corneal view, the eyes become very prominent. This has been called as the frog eye sign. However, that's not important. You're seeing that the cranium is not there. So this is anencephaly, is what you have to remember. It's the earliest anomaly, can be diagnosed in the first trimester itself, as early as around 10 weeks. You can diagnose it. How can it be prevented? It can be prevented by giving a higher dose of folate, right? So anti-epileptic drugs are associated with this teratogenic effect. Give a higher dose of folate. Normally, a female takes 0.5 mg OD. Here we will give 5 mg OD, and it started 3 months prior to conception, right? So this is what you want to remember. Next, what do you see here? We are seeing that within the G-sac, there are two blebs. So this is what is called as 4 mg or 5 mg. So 4 mg, if it is there, you mark that. Normally, 5 mg is the prescription. It's the dose जो market में मिलता है. 4 mg tablet नहीं मिलता. So जो भी option में है. Okay. So this is the double bleb sign. All right. So double bleb sign is basically between the amniotic sac and the yolk sac. So they've asked what are the two blebs. So you are seeing the yolk sac and the amniotic sac, two sacs within the gestational sac, double bleb sign. Next. Yeah, Pulkit, it can be started in the first trimester. If the patient has not taken prior to conception, start from the day that she visits the ANC clinic, Right, going on to thoracic radiology now. So very, very important. ये आपको trauma के context में usually पूछते हैं. So they can tell you that there's history of trauma. And then this is the X-ray. So what is the diagnosis? Yeah, this is pleural effusion. Right side, left side. So this is right and this is left. So left sided, you are seeing this meniscus here. So this is a pleural effusion. Mediastinal shift kaise hoga? Opposite side. So there will be contralateral mediastinal shift. It is pushed to the opposite side. Okay. But in context of trauma, if I ask you, in context of trauma, you will say that it is hemo pneumothorax, right? अगर history of trauma है तो blood है, will look the same. So this is hemothorax here. What will you do? What is your next step in trauma? अगर patient को breath dyspnea है and you see hemothorax on the X-ray, what will you do? A, ICD, B, needle thoracostomy, C, needle thoracostomy followed by ICD. So the management is ICD. If I put a needle, क्या हीमोथोरैक्स ड्रेन हो जाएगा? एक 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 ड्रॉप निकलेगा, आपका पेशेंट स्टेबल हो जाएगा उससे? पेशेंट विल नॉट बी स्टेबल, राइट? सो रिमेंबर, नो रोल ऑफ नीडल इन ब्लड इन हीमोथोरैक्स. ओके, नेक्स्ट स्टेप इज ICD. Now comes the question जिसका आंसर आपने याद रखा है, is needle thoracostomy. So if I give you this X-ray, tell me the diagnosis. Patient underwent chest trauma, now presents with shortness of breath. What is your diagnosis? Right side or left side? Right side. You are seeing that there is this hyperlucent lung. There are no markings. Normally भी तो lungs black है, but here what you are seeing is that there are markings, and here there are no lung markings. Okay, so this is hyperlucent lung without any bronchovascular markings. Okay, so this is pneumothorax. कौन सा side? Right sided pneumothorax. अब is this tension pneumothorax? How will you decide? We have to look at vitals. So if I tell you patient stable है, what will your next step be? Patient का BP ठीक है. Next I will go for ICD. सीधा ICD डाल दो. But if the patient is unstable, patient is in shock, then what is my next step? Now my next step is to put a needle. अब डालो needle. Needle thoracostomy followed by ICD. कहाँ डालोगे needle? Fifth intercostal space, mid axillary line. Where will you put ICD? ICD is put in triangle of safety. How is triangle of safety formed? Which muscle is anterior? Pectoralis major. Which muscle is posterior? Latissimus dorsi. Remember हम याद करते हैं lady between two majors, तो याद रखो lady and major. Okay, so P major and lady, and नीचे क्या है? नीचे is the fifth intercostal space. So this is how you put both needle, ICD. Everything is clear, all of you guys. Now let's talk about the signs. So this is M mode ultrasound. First one, can you see there are lines, and then it becomes granular. तो ये हो गया seashore. अभी कोई आपको बोले चल चल गोवा चलते हैं, चल चल गोवा चलते हैं, what will you do? My video went away. You will say no, I will not go to Goa till 20th of Jan. After that we will go. So हम कब जाते हैं गोवा बीच? Normal times में, not during exam time. Okay, so Sakshi, this is how you distinguish. When you see line, and then granular, this is Goa, this is seashore. But look here, when you see just line, ऐसा कुछ beach नहीं बना, then what is it? It is barcode or stratosphere. समझ में आया? Both of these are signs of pneumothorax. I don't have to remember. मुझे क्या याद रखना? I just have to remember कि भाई seashore normal. Anything else that they name is pneumothorax. Yeah. So this is what you have to understand here. Can I go to the next image? Are you guys okay? We are almost halfway through the slides and halfway through the time. Wow, this is the first time ever that I am running on time. So what we are having here are 3 HRCT appearances. First one, diagnosis बताओ जल्दी जल्दी, because you guys are answering really well and I'm very happy कि हमारा radiology at least intact है through all of these months that we have studied. So I'm very happy. What we see here is a consolidation. So we have a white lung, and what do you see? That the bronchus is black here. So consolidation with air bronchogram sign. You are seeing that the bronchus is filled with air. Okay, so this is what you have to remember. Thank you so much, Amina, for your kind words. So consolidation, air bronchogram sign. ये repeat neat question है, so it can come in the exam. What do you see here? I am seeing that there is a tree in bud, है ना? ऐसा budding लग रहा है. So it's the TB which is spreading through the bronchus. So this is active tuberculosis because the TB has gone inside the bronchus. So this is endobronchial spread of tuberculosis. ये क्या है? Normally, first of all, what are all of these investigations? ये तो पूछने ही भूल गई. A, HRCT, B, NCCT, C, CCT, D, MRI. वेरी नाइस। जब लंग दिखे, है ना, व्हेन यू आर सीइंग द लंग्स एंड एवरीथिंग एल्स हैज बिकम वाइट वाइट, इट्स एन HRCT। दिस इज व्हाट वी डू फॉर द लंग्स, है ना। तो लंग्स का कुछ भी हो, इन्वेस्टिगेशन ऑफ चॉइस बिकम्स HRCT, ठीक है, वेरी नाइस। So now when I look at any HRCT, what we will see is normally white artery and black bronchus are same in size. When there is bronchiectasis, what will happen? Artery stays white, but now the bronchus becomes dilated. So it looks like a signet ring. Can you all visualize this? कि ये white artery हो गई and then there is this black bronchus which is dilated. So this is the signet ring sign which indicates bronchiectasis, dilatation of the bronchi, irreversible permanent dilatation. All right, so 3 DDs हो गए on HRCT. Let's look at the next one. What do we see here? I am seeing that there are multiple nodules and कैसा nodule है? अंदर white है and then look at the periphery. The periphery is very hazy, isn't it? So center is solid and periphery is very hazy. This sign is what we call as the halo sign. Halo बन गया है ground glass opacity का. And this is what is seen in invasive aspergillosis. So fungal infection, invasive aspergillosis. थोड़ा माइक्रो इंटीग्रेट करके बता दो, एस्परजिलस में अक्यूट एंगल ब्रांचिंग होगा या ऑब्ट्यूज एंगल ब्रांचिंग होगा? अक्यूट एंगल ब्रांचिंग होगा। सेप्टेट होगा, ए सेप्टेट होगा? सेप्टेट हाइफे दिखेंगे, ए सेप्टेट हाइफे दिखेंगे? सेप्टेट हाइफे दिखेंगे। एंड सी एस्परजिलस इज सो क्यूट, वो आंसर अपने नाम में लेके चल रहा है, ए फॉर अक्यूट, SP फॉर सेप्टेट। ओके, दैट इज व्हाट यू विल रिमेंबर। एंड व्हाट इज द ड्रग ऑफ चॉइस फॉर दिस? द ड्रग ऑफ चॉइस इज गोइंग टू बी voriconazole. Okay, so voriconazole is the drug of choice for invasive aspergillosis, and here the patient will either have neutropenia or they will give you HIV/AIDS. So basically immunocompromised patients will be mentioned to you. Okay, all right. कोविड के जीजीओ से कैसे डिस्टिंग्विश करेंगे? सी, यू आस्क एंड आई आंसर. व्हाट डू यू सी हियर? वी आर सीइंग दैट देयर आर मल्टीफोकल पैची जीजीओस. क्या यहाँ पे कोई हेलो है कि नोड्यूल है राउंड राउंड, उसके पीछे जीजीओ है? नो, इट इज जस्ट जीजीओ, नो नोड्यूल्स. सो व्हेन यू सी मल्टीफोकल, बहुत सारे पैची peripheral GGOs, that is what is our COVID-19. So if I ask you कि मुझे CORAD score देना है, what score will I give this patient? 1, 2, 3, 4, 5? 5. CORAD's 5 means it is typical for COVID-19, right? So when I say CORAD's 5, it is typical. If this patient says, Doctor Sahab, aap kya CORAD's doge? I am RT-PCR positive only. I know I am COVID-19. Then what score will you give? Then you will give 6, right? So if patient is RT-PCR positive, then we give a score of 6. CORAD's 6. All right. So this is what you have to remember, that this is typical COVID-19. अब जाके COVID का question I बहुत unlikely है, but still you shouldn't get it wrong, because now again there is resurgence. Touch wood, prayer, ऐसा कुछ ना हो. It's not a major resurgence, but still, you never know. Anyways, what we are having here are multifocal chota nodules like millets. Again, you should know 2023 is, no, was the year of millets. Yeah, अब तो was हो गया. So year of millets था according to WHO. So you may be asked that. But these are small nodules that you are seeing here. So this is miliary tuberculosis. All right, so this is miliary tuberculosis. It is always going to be bilateral because it is hematogenous spread. The TB is spreading via the bloodstream. Okay, so this is miliary TB. What is this year? Abhi tak I don't think they have announced yet. Okay. चलो अगला क्या है? नाउ यू हैव टू टेल मी दिस ओपेसिटी इज इन द राइट मिडल लोब, राइट लोअर लोब, राइट अपर लोब, लेफ्ट मिडल लोब दैट इज लिंगुला, और लेफ्ट लोअर लोब. सो ऑब्वियसली यू विल बी लाइक मैम राइट है, लेफ्ट तो नहीं है ना. सो वी हैव two options now. It can't be right upper lobe. Right upper lobe is upper. So it is either middle lobe of the right side or the lower lobe. So when I see that it is spreading, it is silhouetting with the heart border, it is merging with the heart border, it is right middle lobe consolidation. So right middle lobe consolidation, remember, will merge with the heart. What do I mean by that? Now look at this X-ray. Can you see this white? Tell me, is it in the right middle lobe, right lower lobe, left middle lobe, that is lingula, or the left lower lobe? आया समझ में? Now I can see that the margins are so clear from the heart, isn't it? So this is not middle lobe. This is left lower lobe consolidation. So इसको बोलते हैं silhouette sign. The silhouette sign basically tells you that if the opacity is merging with the heart, I can't make out the boundary, it is in middle lobe. But if I can make out that भाई तुम अलग हो, heart अलग है, it is in the lower lobe. Did you understand silhouette sign, all of you? If they also give you a lateral radiograph, then I see ki, okay, this is overlying the heart, it is middle lobe. If the opacity is behind, it is lower lobe. So this is how you have to approach this silhouette sign. Exam में नहीं दिख रहा है तो क्या mark करोगे? You are not confident in the exam. How will you take a guess? Middle lobe. Exam में पूछा है तो middle lobe मार देना if you are not sure. Okay? But आई थिंक नाउ यू अंडरस्टूड. तो समझ आ जाते तो समझ के करना, नहीं समझ आता तो मिडल लोब मार देना. ओके, moving on to the next one. If you have a young male who's having HIV, CD4 count less than 200, non-productive cough, and I see hazy. Can you all agree with me कि मैम ये ना ground glass लग रहा है? This is GGO bilateral. So when you see HIV patient with bilateral ground glass opacity, what is it? It is PCP. It is pneumocystis cerevisiae or pneumocystis carinii infection. Very typical HIV history will be given. टीबी हमने देख लिया, ट्रीन बर्ड. Pneumococcus is going to produce your lobar pneumonia, consolidation with air bronchogram. Invasive aspergillosis we have seen, halo sign. So बाकी सारे देख लिए, only PCP, right? So yes, drug of choice is cotrimoxazole. Prophylaxis is also cotrimoxazole. All right. Collapse and consolidation meet, you will see volume loss. So at your level, they will not ask you to distinguish collapse and consolidation. Collapse में volume loss हो जाता है. So the lung will appear smaller. You know, that is how you can remember. Fine. Moving on to two popcorns. I didn't skip anything. Yeah, moving on to popcorns. Two popcorn sign that you should know. अगर mammography में popcorn है, what is this? Fibroadenoma, right? So this is a fibroadenoma that you are seeing here, a benign tumor of the breast. And if you see it in the lung like this, a calcified popcorn lesion, what is this? It's a pulmonary hematoma. It's the most common benign lesion of the chest. Okay. Right. Moving on to 4 congenital heart diseases. You have PEDS, which is there next. So I'm sure sir is going to talk about it. But just quickly going through it. When you see a boot-shaped heart, core and sabit, it's a tetralogy of Fallot. When you see a box-shaped heart, it is Epstein's anomaly. And what is the kind of history that they're going to give you here? They're going to give you that maternal intake of lithium. It's a teratogenic effect of lithium. When you see that it's looking like an egg on string sign, what is it? It is transposition of great arteries. The arteries have gone from one side to the other. And when you see this figure of 8 or a snowman sign here, what is this? This is TAPVC, totally anomalous pulmonary venous communication. Which type? Very nice. All of you are telling me the type also. The most common type, that is supracardiac. Now, a lot of you will confuse box and egg on string. So the idea here that you have to remember is not the heart which will tell you answer. What do you have to look for to tell the answer? You have to look for the lungs. Agar lungs black lag rahi hai, what do we call that? We call that oligemia. Here in Epstein's, you will see oligemia. Why? Because what happens in Epstein's? You will see that the right atrium is very big and right ventricle is very small. So the pulmonary artery becomes very small. That's why the lungs will not have pulmonary arterial flow. They will appear blacker. On the other hand, TGA में क्या लगेगा? TGA में दिखेगा that from right ventricle I have aorta and from left ventricle I have pulmonary artery. So what will happen? Pulmonary artery will now get a lot of blood. So अब lungs देखो, I'm seeing lots of markings. तो इसको क्या बोलते हैं? इसको बोलते हैं plethora. Understood this everybody? So you will actually have to see the lungs to distinguish. बाकी दो के तो sign काफी clear है. It does look like boot, it does look like figure of eight. So congenital heart disease का एक मार्क गलत नहीं होना चाहिए कभी. Okay, all right. चलो आगे बढ़ते हैं. टू पैथोलॉजीज हियर. इससे पहले थोड़ा अनाटमी बता दो. व्हाट इज दिस वेसल दैट आई हैव मार्क्ड हियर? अच्छा, सबसे पहले बताओ कि सीटी है, एमआरआई है, एक्सरे है, अल्ट्रासाउंड है. बोन इज वाइट, सीटी. एनसीसीटी है, सीसीटी है. वेरी नाइस. कॉन्ट्रास्ट देख लिया, एओर्टा वाइट वाइट है. कॉन्ट्रास्ट एनहांस्ड सीटी स्कैन. वंडरफुल. तो अब ये बताओ ये वेसल कौन सा है? सो वी रिमेंबर सैम, है ना? सैम इज अवर ट्रिक. तो कौन है ये वेसल सबसे राइट साइड में? इट इज एसवीसी. ए से ये वेसल कौन सा है? बिग वेसल. दिस इज ए फॉर असेंडिंग एओर्टा, विच इज दिस वेसल विच bifurcates to form this V here. It is the main pulmonary artery dividing into right and left. So SAM याद रखेंगे, SVC, aorta and main pulmonary artery. And this posterior vessel here is what? It is descending aorta. ठीक है. अब ये देखो, what are these two vessels? Or vessels? Are they vessels? No, they are air filled, they are bronchi. So right main stem bronchus and left main stem bronchus. Okay, so anatomy clear ho gayi. So which is the vessel which is abnormal here? It's definitely ascending aorta which is dissected. So their diagnosis here is aortic dissection. So in any stable patient, investigation of choice is going to be a CT, right? A CT angiography. CT angiography is the same as CCT, है ना? Same as CCT, just that हम artery में ज़्यादा contrast देते हैं. So stable, but patient is unstable, can't even go for CT. Then what will we do? Then we will do a transesophageal echocardiography. Bedside echocardiography से we can pick up this dissection flap here. Okay. Yeah, so you want to know between true lumen, false lumen. So true lumen is always going to be whiter, है ना? छोटा होगा और ज़्यादा white होगा because it receives more contrast. So when you see the whiter lumen, that's the true lumen. दूसरा false है. इसमें right left कैसे पता चलेगा? Same. तो ये right side है, ये left side है. This is the right lung, this is the left lung. Like everything else. What is the classification that we see here to decide management? So we see the not Strassman, Stanford. Yeah. So Stanford classification and D-Bakey classification. So we have Stanford A and Stanford B that you should know. So anytime when ascending aorta is involved, it is Stanford A, urgent surgical management. If it is only descending aorta, you can just give medical management with beta blocker, IV, esmolol. ठीक है. Dye used for angiography is iohexol, iodinated contrast. Okay. ऑल राइट, तो यही सैम को यूज करके बताओ कौन सा वेसल इसमें अब नॉर्मल लग रहा है. SVC हमेशा ऐसा, vein will always look heterogeneous. That's okay. This is ascending aorta, which is okay. But now look at the pulmonary artery. I am seeing that there is this embolus here, isn't it? So this is pulmonary embolism. Again, pulmonary embolism, investigation of choice is a contrast enhanced CT. But what do I call it? I call it a CT pulmonary angiography. Look here. Can you see how pulmonary artery is the whitest? है ना? इसलिए उसका नाम रखा है pulmonary angiography. Aorta तक तो contrast भी नहीं पहुंचा. It has not even reached till the aorta. Okay, so this is pulmonary embolism. All right, moving on to neuro rad. So we have neuro, MSK and general rad to go. Are you guys okay? हाँ, चलो next 15 minutes let's finish neuro. All right, so very, very important. One of these will come. So 4 conditions I am giving you. NCCT, whenever you see something white on a non-contrast CT, it is acute hemorrhage. Now you have to see the shape. Is the shape like a crescent? It is crossing and it is like a crescent, and history में है trivial fall, alcoholic fall, elderly falling in bathroom. ये क्या बनेगा? This is acute subdural hemorrhage. But if I see severe trauma, and what do you see? It is like an idli. It is biconvex idli. This is extra dural hemorrhage. So when the image doesn't help you, you look at the history. That will definitely help you. SDH is a trivial trauma, venous injury hota hai. EDH is a severe trauma. You're gonna have arterial bleed. If I ask you which artery, middle meningeal artery, which division? Anterior division, posterior division? Anterior division. Why does it break? Why does it rupture? It ruptures because of the trauma to the pterion, right? So MMA runs just below the pterion, which is the point of meeting of all four sutures. So because it runs below the pterion, whenever there's a pterional fracture, there's going to be EDH. Lucid interval is more typical with EDH or SDH? EDH, right? So lucid interval is that brief period where a patient will regain consciousness before losing it again. That is more common in EDH. अगर पेशेंट ने अपना विल या कुछ बता दिया ड्यूरिंग लूसिड इंटरवल, इज दैट कंसिडर्ड टू बी वैलिड? क्या उसको हम मानते हैं फ्रॉम फोरेंसिक पॉइंट ऑफ व्यू? मानते हैं, राइट? सो इट इज समथिंग विच इज एक्सेप्टेड. वॉट एवर ही सेज ड्यूरिंग लूसिड इंटरवल इज वैलिड. एक और अनाटमी क्वेश्चन बताओ. बिलो द टीरियन, what is the bony landmark that you will see? Greater wing of sphenoid, lesser wing of sphenoid, body of sphenoid? Yeah, so lesser wing of sphenoid. ये दोनों repeat questions है. So below the pterion you have one artery and you have one bone which is lesser wing of sphenoid. ठीक है, चलो बहुत बढ़िया. अब ये भी बता दो, middle meningeal artery courses through which foramen of the cranium of the skull? फोरामेन स्पाइनोजम है ना. फोरामेन स्पाइनोजम में से मिडल मेनिंजियल आर्टरी रन्स. ओके, बहुत बढ़िया. अब अगर मुझे आरटीए का हिस्ट्री एंड आई सी दिस वाइट वाइट एज अ स्टार ऑफ डेथ, व्हाट इज दिस? दिस इज सब एरिकनॉइड हीमरेज. सब एरिकनॉइड हीमरेज एक तो ट्रॉमा इज द मोस्ट कॉमन कॉज. बट इफ आई टेल यू मोस्ट कॉमन कॉज ऑफ स्पॉन्टेनियस एसएच, ट्रॉमा हुआ ही नहीं फिर भी एसएच हो गया. Very severe headache, thunderclap headache. Very nice. It is berry aneurysm, right? So berry aneurysm rupture is the most common cause of spontaneous SAH, and which is going to be the most common artery where a berry aneurysm ruptures or a berry aneurysm forms. It is at the junction of the ACA, anterior cerebral artery, and the anterior communicating artery, है ना? So junction of ACA ACOM is where most commonly we have berry aneurysms. ठीक है, बहुत बढ़िया. अब मैं आपको दे रही हूँ एक एल्डरली पेशेंट हु इज हैविंग अ सडन राइट साइडेड हेमीप्लीजिया. यू डू द सीटी एंड यू सी दिस वाइट हेमाटोमा. व्हाट इज द एरिया इन्वॉल्व्ड? वेरी नाइस. तो थोड़ा अनाटमी बता दो. व्हाट इज दिस बेसल गैंग्लिया नियर द लेटरल वेंट्रिकल? ये क्या है? ये वाला दोनों तरफ, दिस इज कॉर्डेट है ना. दोनों साइड ऑफ द लेटरल वेंट्रिकल इज कॉर्डेट. व्हाट इज दिस वन? This is the lentiform. This is what is bleeding here. So this is the lentiform which is made up of two parts. What two parts? Outer putamen and inner globus pallidus. So outer putamen, inner globus pallidus. And out of this, if they ask you what is the most common site of bleed, it is putamen. है ना? So putamen is the most common site of bleed in hypertensive patients. So usually hypertensive males will have this putaminal bleed here. And ये जो छोटा सा ventricle है, सीधा ventricle is the third ventricle, and thalamus is on both of the sides. And the white matter bundle which runs in between is what? That I'm drawing with yellow. It's the internal capsule. ठीक है, तो इसमें से कुछ भी अनाटमी क्वेश्चन आ गया, विल यू मार्क इट? एवरीबडी, चाहे वो कडावर हो, सीटी हो, एमआरआई हो, अनाटमी रिमेन्स द सेम. ओके, perfect. So this is about our bleeds. Okay, so NCCT, white in the brain, is acute hemorrhage. All right. Okay, but what if I tell you कि RTA रोड ट्रैफिक एक्सीडेंट है, या इट्स इंट्रा पैरेनकाइमल, तो इसको आप इंट्रा पैरेनकाइमल ब्लीड बोल सकते हो, बेजल गैंग्लिया ब्लीड बोल सकते हो, प्यूटामिनल ब्लीड बोल सकते हो, है ना? ओके, कमिंग बैक. रोड ट्रैफिक एक्सीडेंट है, लो जीसीएस, तो जीसीएस एकदम खराब. बट व्हेन आई लुक एट द सीटी, तो हमें सीटी पे ओनली स्मॉल माइक्रो ब्लीड्स आई एम सीइंग, पर्टिकल ब्लीड्स आई एम सीइंग. समटाइम्स इट मे बी नॉर्मल आल्सो. सो देन व्हाट इज योर डायग्नोसिस? डायग्नोसिस बन जाएगा डिफ्यूज एक्सोनल इंजरी. इट इज नॉट द वेसल्स व्हिच हैव बीन इंजर्ड, इट्स द एक्सॉन्स. छोटे छोटे एक्सॉन्स टूट गए हैं. दैट्स व्हाई द जीसीएस इज वेरी लो. So diffuse axonal injury, what I'm going to see are these small microbleeds. This is the only place in trauma where investigation of choice is what? It is MRI. And अगर मैं आपको difficult question पूछूं कि ये MRI में कौन सा sequence है, you're already answering. Very good. It is susceptibility weighted image, not DWI, SWI. Okay, so susceptibility weighted imaging. I'll give you a trick here. दो इन्वेस्टिगेशन में मिक्स होते हो, DWI, SWI. डिफ्यूजन वेटेड इमेजिंग हम यूज करते हैं इन स्ट्रोक, ससेप्टिबिलिटी वेटेड इमेजिंग हम यूज करते हैं डिफ्यूज एक्सोनल इंजरी. तो ये बन जाता है हमारा क्रॉस न्यूमोनिक, है ना, हम बीटीआर में क्रॉस न्यूमोनिक पढ़ते हैं. तो दिस इज अवर क्रॉस न्यूमोनिक दैट यू हैव टू रिमेंबर, दैट डी के साथ एस, एस के साथ डी. ऑलराइट, coming back. So diffuse axonal injury, susceptibility weighted imaging, you will see these kala black dots. Okay, yeah, so this is about this. चलो आगे बढ़े. एंटीनेटल अल्ट्रासाउंड करा किसी का एंड दे विल नॉट गिव यू दिस इमेज, वो आपको लिखेंगे उसमें कि उसमें मुझे लेमन साइन एंड बनाना साइन दिख रहा है. व्हाट इज द डायग्नोसिस? So they'll not ask you to diagnose lemon banana on images, they'll ask you just the diagnosis here. Good. So either the option will give you spina bifida or it might mention Chiari. So the better answer is Chiari malformation type 2. But if this is not there, then you will say spina bifida. Okay. All right. How to distinguish between chronic hemorrhage and ischemia? So they will not ask you that basically, but both will be hypodense on CT. That's why MRI is better to distinguish them. All right, so both will be hypodense on a CT scan. So very difficult to distinguish. All right, so spina bifida, Chiari 2. All right, so I'm going to show you 6 tumors now. 3 in adult, 3 in children. You just diagnose with one pattern. Okay, so pehla, I will give you one hint. It is the most common benign ट्यूमर इन अडल्ट्स. वंडरफुल. क्या दिख रहा है? एक टेल दिख रही है, ड्यूरल टेल साइन. तो क्या डायग्नोसिस बना? मेनिंजियोमा. चलो साथ साथ पैथ भी पढ़ लेंगे. पैथ में क्या दिखेगा मेनिंजियोमा में? What bodies? Yeah, Samoma bodies is what you will see in meningioma. Wonderful. Then look at this. My hint for you is this is most common malignant tumor in adults. What are you seeing? Seeing that it is crossing over to the other side. है ना? Butterfly tumor, the only tumor which will spread on to the other side. This is glioblastoma multiforme, grade 4 tumor. Histopath में क्या मिलेगा? I will see one cell over the other. इसको बोलते हैं pseudo palisading, right? So you will see pseudo palisading on histopath. Next one, you see one ice cream cone. This is at the junction of the cerebellum and the pons. Cerebellopontine angle. Ice cream cone tumor. क्या है ये? This is our acoustic schwannoma. ENT में पढ़ेंगे. Acoustic schwannoma rising from the 8th cranial nerve, right? So this is what you will see. And इसमें histopath में क्या मिलेगा? बहुत important. I will see one very cellular area and I will see one acellular area. So these are Antony A and B areas. And इसमें जो Antony A में bodies है उनको क्या बोलते हैं? Those are known as Verrucae bodies, right? So those are Verrucae bodies which are the cellular areas here. ठीक है. सो ये हो गए 3 अडल्ट के ट्यूमर. अब बात करते हैं 3 बच्चों के ट्यूमर. इफ आई टेल यू दिस इज द मोस्ट कॉमन बिनाइन ट्यूमर इन चिल्ड्रन, देयर इज अ सिस्ट विथ अ नोड्यूल इनसाइड इट. व्हाट इज इट? या इट इज अ पिलोसिटिक एस्ट्रोसाइटोमा. सेरिबेलम में मोस्ट कॉमनली मिलता है. दिस इज द वन क्वेश्चन विच हैज बीन आस्क्ड द मोस्ट. इन फैक्ट दे जस्ट आस्क यू व्हाट इज द लोकेशन ऑफ दिस ट्यूमर. So you see that it's the pons anteriorly, ये pons है and पीछे cerebellum है, sagittal image है. So this is the 4th ventricle. So when you see a tumor in the 4th ventricle, what is this? This is our medulloblastoma, the most common malignant tumor in children. ठीक है. म से malignant, म से medulloblastoma. Yes, it can have drop metastasis as well. And then the last one, if I tell you it's a child with a calcified, the only place where I'm showing you a CT because it's a white calcified tumor. It's a cystic tumor. What is this? C से ही craniopharyngioma. So ऐसे करके याद रखना है. C's, all C's will stick together here. Craniopharyngioma. This has been asked a lot of times. C से ही, it is near the sella. It can compress the optic कायाज्मा. जब ऑप्टिक कायाज्मा कंप्रेस होता है कैसा विजुअल डिफेक्ट मिलेगा? Temporal fields, right? So the both the nasal fibers cross at the chiasma, so the temporal fields will go. So it is bitemporal hemianopia. So there they can give you a child with bitemporal hemianopia. Always think of a craniopharyngioma. ठीक है, चलो 3 CNS infections करेंगे very quickly. What do you see here? There is one big abscess, isn't it? You see one peripheral enhancing lesion. This is a brain abscess. If you see multifocal lesion, starry sky appearance, सबके center में एक scolex है. What is this? Neurocysticercosis. Tinea solium is the most common cause here. And if I tell you this is patient with HIV AIDS, and you see that there are these ring enhancing lesions in the basal ganglia, the moment you hear brain and you hear HIV, एक ही चीज दिमाग में आना चाहिए, which is toxoplasmosis. Yes, are you guys doing okay? Speed fast है, but I can see you are answering and you are catching up, which is great. Okay, so abscess, NCC, toxoplasmosis. Fine, so 3 infections. Most common cause, benign tumor of child of brain is craniopharyngioma, pilocytic astrocytoma. Okay, not craniopharyngioma. चलो 2 PNS views. What is this view where I'm seeing the maxillary sinuses very nicely? Water. But अगर मैं बोलूँ कि open mouth waters, modified waters, Pierce view, what is better answer? Yeah, Pierce. So either Pierce view is there in the option or a modified waters. Prefer that because you are seeing that the mouth is open mouth क्यों करवाया है? Because when the mouth is open you will also see the sphenoid sinus, है ना, पीछे से sphenoid sinus भी दिख जाएगा. So that is always preferred. So this is the Pierce or the modified waters view. It's the best X-ray view for maxillary sinuses, isn't it? So you are seeing how on the right side, can you see यहाँ पे एक level बन गया है. So this is our maxillary sinusitis. On the other hand, if I ask you ये कौन सा view है, you will see that अरे maxillary sinus के ऊपर तो bone आ गया है. Alright, so this is something which is Caldwell's view. Alright, so this is Caldwell's view and it is the best for seeing the frontal sinus. Okay. One of you has asked, ma'am, how to distinguish toxoplasma and CMV. So that is congenital. ठीक है, ये कैल्शियम नहीं है, ये कॉन्ट्रास्ट है. सो दिस इज इन्फेक्शन. बट जब हम टॉर्च की बात करते हैं, कंजेनिटल टॉर्च इन्फेक्शन, देन यू कैन हैव कंजेनिटल सीएमवी एंड यू कैन हैव कंजेनिटल टॉक्सो. उसमें हमें कैल्सिफिकेशन दिखता है. सीएमवी का कैल्सिफिकेशन इज गोइंग टू बी पेरीवेंट्रिकुलर, अराउंड द वेंट्रिकल. सो वी से सीएमवी, वी से पेरीवेंट्रिकुलर. इन टॉक्सोप्लाज्मोसिस व्हाट आर वी गोना सी? इन टॉक्सो वी आर गोना सी पैरेनकाइमा, है ना. तो ब्रेन में पैरेनकाइमल कैल्सिफिकेशन विल बी सीन. ओके, सो दैट इज डिफरेंट. ऑलराइट, बेस्ट फॉर sphenoid? No, no, best for frontal sinus. Okay, sphenoid is not seen actually, you know, very well on Caldwell में तो दिखता ही नहीं है. Even in Pierce we just see this. Alright, so nowadays I don't do these views at all. If I ask you अब क्या करते हैं, what is the investigation of choice for paranasal sinus, what will your answer be? HRCT again, right? Like what we did for lungs, we'll do a CT scan for the paranasal sinus. It's going to be HRCT, which is the investigation of choice. Ethmoid and all we see thoda in all of the views, but nothing is really best, you know, for ethmoid. CT is what we do. ठीक है, चलो ये क्या है? Very easy. What are you seeing? I am seeing that the maxillary sinus on the right side is being pushed by this mass here. So this is the Hohmann-Miller sign. Diagnosis बताओ. जैसे ही मैंने पढ़ा कि भाई juvenile young male with epistaxis, it is juvenile nasal angiofibroma. No. One of you is asking modified waters is also the best for maxillary only. Waters is also best for maxillary only. We don't do waters anymore. सिर्फ mouth खुलने से we can also comment on the sphenoid sinus, है ना. तो हम यही करते हैं, but still it remains the best for maxillary sinus only. ठीक है, चलो वापस चलते हैं into JNA. So the moment I have a young male with epistaxis, it is JNA, and this is the Hohmann-Miller sign where the posterior wall is going to be pushed anteriorly. Okay, चलो very quickly going into MSK radiology. बोन ट्यूमर्स ऑर्थो में भी पढ़ोगे, बट जस्ट आई विल रिवाइज विथ यू वेरी क्विकली. सो व्हेन यू सी एपिफिजियल ट्यूमर रीचिंग अप टू जॉइंट सरफेस, क्या याद रखते हैं? ईसीजी याद रखते हैं. सो टू एपिफिजियल ट्यूमर्स, इफ you don't know answer, you see distal end of radius, you see soap bubble appearance, you have to mark giant cell tumor. You want to know the other signs? Yeah, very quickly I'll tell you. So the dot sign or the crescent sign is what we use for polyp. All right, so nasal polyp comes behind, a lateral x-ray may be given to you. So this is seen for antrochoanal polyps. Phelps sign, anybody knows where we see Phelps sign? It is seen in glomus jugular, right? So in glomus tumors, you will have destruction of the jugular spine, which is the Phelps sign. And Greisinger sign is a complication of CSOM where you have a lateral sinus thrombosis. So what you will see is this erythema behind the ear. Do you know the battle sign? Battle sign में कान के behind में erythema मिलता है. So अगर वो trauma है तो वो battle sign है. अगर trauma नहीं है and they are giving you history of CSOM and what looks like a battle sign, that is your Greisinger sign. Okay, so that's erythema because of the transverse sinus or the lateral sinus thrombosis. ठीक है, चलो चले वापस. सो वी डिड जीसीटी. इट विल बी अ 30 to 40 year old patient, middle age patient with a soap bubble appearance on the epiphysis. If you see an epiphyseal tumor in a child less than 20 years and you see that the growth plates are not fused, what is that? It is chondroblastoma. ठीक है, तो ये है chondroblastoma. So C से child, C से chondroblastoma. Okay, this is what you have to remember here. Next, Caldwell is AP view or PA view? AP करते हैं वैसे, but not important. Okay. Next, what do you see here? If I give you history of nocturnal pain relieved on taking NSAIDs, I am seeing that there's a chota sa lesion. CT is the investigation of choice. Seeing a nidus which is producing prostaglandin. कौन सा prostaglandin? E2. Pain है ना, so we remember E for pain, right? So this is prostaglandin E2. This is osteoid osteoma. Okay, so diaphyseal tumors, two diaphyseal tumors. One is osteoid osteoma, and when I see a child with a huge soft tissue, onion peel, periosteal reaction, multilamellated periosteal reaction. This is Ewing's sarcoma. So both of these are diaphyseal. This one is very small, this one is very big. Okay, so osteoid osteoma, what is the treatment of choice? Only this nidus is a problem, that is releasing the prostaglandins, right? तो वही nidus को जला दो. So what we do is radio frequency ablation here. Ewing sarcoma, what is the treatment of choice? Is it a radiosensitive, chemosensitive tumor? Yes, the most radio chemosensitive because this is a small round blue cell tumor. It is something which has a lot of cells, hypercellular tumor. That's why it is chemo radiosensitive. So chemo radiotherapy combination is used for Ewing sarcoma. This has been tested. It is the most radio sensitive bone tumor. Okay, and finally what do you see? You see uplifted periosteal reaction, Codman's reaction, and you see that there is a sunburst periosteal reaction. This is osteosarcoma, right? So this is osteosarcoma, right? Is this radiosensitive? No, it is the most radio resistant bone tumor. So here the treatment remains surgical excision. All right, so this is what you have to remember for all of these bone tumors. Three tumors जो आजकल हर एग्जाम में आए. In the last three exams, NEET and FMG, you've had one of these coming alternate years. ये क्या है? When you see that a tumor is growing away from the joint, it is an osteochondroma or an exostosis. MRI will show you this cap, cartilage cap. Is this important to see this cartilage cap here? Yes, it is very important because when the thickness becomes more than 1.5 centimeter, it means that it has turned into chondrosarcoma. It doesn't become osteosarcoma, it becomes chondrosarcoma. So it should be removed. So we measure this cartilage cap thickness on MRI because there is risk of this becoming chondrosarcoma. Osteochondroma, other name is exostosis, right? Grows away outside exostosis. ठीक है. ये वाला बताओ क्या है? द मोमेंट यू सी हैंड, हैंड ए एन को बना दो ई एन, ई एन से क्या याद रखोगे? एन कॉन्ड्रोमा। सो मल्टीपल एन कॉन्ड्रोमास इन दी हैंड, इस सिंड्रोम को क्या बोलते हैं? Olier's syndrome. But if I tell you that there are additional hemangiomas also, फिर बताओ कि क्या है? Maffucci syndrome, right? Then we call it Maffucci syndrome. Very nice. ये बता दो क्या है? The femur is bent like a shepherd crook. So shepherd crook deformity. This is fibrous dysplasia. Fibrous dysplasia, shepherd crook deformity. All right. So this is what we have to remember here. Next, if I tell you a young male is presenting to you with backache, heel pain, you see a completely fused spine, bamboo spine, इसको गलत नहीं करना. What is this? This is ankylosing spondylitis. Very good. So this is ankylosing spondylitis. Young male will be there. HLA-B27 positivity is what you will see here. 5 spine spotters for you. If you see an old postmenopausal female coming to you with backache and this is the x-ray, what are you seeing? You're seeing that the bones are black, density is gone, and the bones are bent like a codfish mouth. This is osteoporosis. If I tell you what will be calcium phosphate ALP in this patient, everything will be normal. It is just a generalized bone mineral density loss. If I ask you what is investigation of choice for osteoporosis, very good. It is the DEXA scan, dual energy X-ray absorptiometry, wherein we see a T score, है ना? Young adult से compare करते हैं density. If it is less than minus 2.5 standard deviation, that is your osteoporosis. Okay, so T-shirt young adults पहनते हैं, ऐसे याद रखो. So young adult से compare करते हैं. अगर age matched adult से compare करते हैं, क्या score देंगे? Z score. ठीक है, तो age matched is Z score and T-shirt T score is what we use in WHO. So T score is what is used. बहुत बढ़िया. Next X-ray देखो, you are seeing alternate white and black lines like a jersey, rugger jersey spine. Diagnosis. This is seen in renal osteodystrophy, right? So secondary hyperparathyroidism, which is hyperparathyroidism seen in patients with renal failure. So secondary HPT, or we can call it renal osteodystrophy. ठीक है, बहुत बढ़िया. Next देखो, what are we seeing? We are seeing that in one vertebra only there is white and then there is black. Lysis and blastic both. So both है Paget's disease. This is what is given the name of picture frame vertebrae. Quickly tell me in Paget's, what will I see in calcium, phosphate, PTH and ALP? What will be the levels? Very nice. Only ALP will increase, everything else will be normal. Isolated rise of ALP is what you find in Paget's disease. Wonderful. What is this? One vertebrae completely white like ivory. So ivory vertebrae, one DD is Paget's only. Paget's का blastic phase में मिल सकता है. Another DD is Hodgkin's lymphoma. And the third DD that is very important is blastic metastasis. Two primaries जिसमें से blastic mets आते हैं, बता दो जल्दी. In male, it will be prostate. In female, it will be breast. And what you have to remember, something very interesting, both of them, how do they spread to the vertebrae? Artery, vein, nerves, lymphatics, what takes it? Vein, right? So it's the venous plexus, Bateson's venous plexus, epidural venous plexus is going to take it. So this is again a question that gets asked. Okay, तो साथ में याद रख लो, prostate, breast, Bateson plexus, blastic metastasis. ठीक है? And lastly, if I give you, there is a child who's having this flattened vertebra plana. What is this? Where is this seen in? Langerhans cell histiocytosis. Okay, so LCH in a child, vertebra plana. Path में क्या पढ़ोगे? कैसे granules मिलती है इलेक्ट्रॉन माइक्रोस्कोपी पे, ऐसे टेनिस रैकेट वाले? Burbeck granules. Very nice. So Burbeck granules. ठीक है, चलो अब फटाफट खत्म हो जाएगा. Just tell me the answers to this. If I tell you that persistent back pain, you are seeing that there is this collection, psoas mein, white, psoas abscess, right? How will the patient present? The patient will have pain, right? The patient will have pain on the extension of the hip, that is known as the psoas sign, and the flexion will be restricted, है ना, flexion नहीं कर पाएगा hip का. So this is about it. Lastly, a few general radiology things. Give me 5 more minutes and we'll be done. Identify the tip of the pacemaker. So so first of all, ये subcutaneous generator हो गया, right? Psoas major or minor? Major. Okay, one psoas only. Okay, so what you have to remember here is there are two leads. Okay, so where are the two leads? Lead number A is in RA, RV, LV. R A, राइट, छोटा लीड है राइट एट्रियम, बड़ा लीड है आरवी और एलवी, आरवी. So if I see a third lead, only then it will be in LV. If you see two leads, it is in RA and RV. Okay, this is how most commonly the leads are placed. All right, so here the answer is going to be right ventricle. All right, so this is how a pacemaker appears. If I ask you, if I want to confirm the position of a pacemaker, if I want to confirm position of NG tube, if I want to confirm position of central line, what will be my investigation of choice? A, X-ray, B, CT, C, MRI, D, ultrasound. Answer will always be X-ray. So for all tubes, the investigation of choice to confirm the position is X-ray, except, can you tell me one tube where answer will not be X-ray? Very nice. One tube will be ET tube. So ET tube is the only tube where the answer is going to be your end tidal CO2 that we measure on capnography. So you can remember it as ET is ET. ET में better is capnography then X-ray. बाकी सब में X-ray is going to be your best investigation to confirm, है ना? तो ये हमारा lines and tubes का question भी answer हो गया. Then comes the mandatory question in every exam, which is foreign body. So young male, hammer chisel, foreign body आंख में चला गया. What is detrimental? Question ध्यान से पढ़ना है कि best पूछा है या worst पूछा है, contraindicated पूछा है. So detrimental माने damaging. MRI contraindicated because metal है and MRI is magnet. So when you place this metal, there is going to be trauma, there is going to be damage, है ना? So MRI is contraindicated. So whenever we talk about a foreign body, initial investigation X-ray, investigation of choice NCCT, contraindication MRI, है ना? तो when this person gets a CT, look here, you are gonna see something so white. So foreign body is whiter than bone also. That's why CT can pick it up very easily. You don't even need to give contrast. ठीक है, आया समझ में? अब ये दो बच्चे देख लो. One बच्चा has eaten coin, one बच्चा is aspirated coin. Which बच्चा is which बच्चा? So when you see that the coin is round, esophagus has a O. So esophagus, you will see the full frontal face of the coin. But when you see a slit like this, it is in the trachea. Then this time INICT, they asked you कि भाई ये coin है, button battery है, bottle का lid है, क्या है? So for that, what are you going to see? If I see a homogeneous white thing like this, it is a simple coin. But if I see that there is one margin and then there is one margin, this is what is a button battery. This is how a button battery will appear. It will show you two margins. All right. So this is how you can know type also of the foreign body. ठीक है? All right. Lateral view confuses? No. Lateral view तो सबसे easy है. Let me show you. I don't have lateral view. Where did I show you lateral view of the X-ray? Lateral view में basically you will see कि काला काला airway है and then पीछे soft tissue है. Here you will see vertebrae, right? So if you see coin is in the काला काला airway, it is in the trachea. If you see behind the trachea, it is in the esophagus. बस तो lateral view will not confuse. They'll not even give you that. They'll give you frontal only. Okay? फाइन. एग्जाम में इतना क्लियर इमेज दिखाएगा क्या? तो अगेन आई डोंट नो कि एग्जाम में क्या आएगा, बट आई होप कि आए. पर मैं पढ़ाऊंगी तो क्लियर में ही ना, मैं अनक्लियर में ही पढ़ के ही जाओगे तो फिर कैसे एग्जाम में आएगा? तो वो तो अब देखना पड़ेगा कि कैसा आता है. कमिंग टू दिस, विच रिब इज मार्क्ड हियर? So everybody is like, ma'am, we know that we have to mark right fourth posterior rib if that is in the option. But do you know the proper method? So let me break it down to you in baby steps. Okay. तो सबसे पहले क्या देखोगे? सबसे पहले यू हैव टू सी कि ऐसा कर्व्ड मार्जिन है या फिर सीधा रिब है. Yeah, that is your first step. So if you see that it's curved, then it's the anterior end. If you see that it is horizontal, like in this case, it is the posterior rib. So at least 50-50% odds पे तो आ गए. Those are good odds, right? कि 50-50 में से ही कुछ तो सही हो जाएगा. So now we know that this is a posterior end. Now we have to start counting. So the biggest mistake that people will do is वो ये 1 कर लेंगे और ये 2 कर लेंगे और ये 3rd कर लेंगे, है ना? This is what you do, all of you. कि ये पहला, ये दूसरा, ये तीसरा. No, you see one more rib is there. So this is the mistake that you make. So this is first, this is second, this is third, and this is fourth. So this is the fourth posterior. And नीचे जाता हो 5, 6, 7, 8, 9, 10. Yeah, understanding everybody. So this is how you have to do. तो अगर समझ में नहीं आया कि मैम 1 कौन सा है, then रिमेंबर दिस कि जो आपको लग रहा है 3rd है वो 4th है. जस्ट एड टू व्हाट यू थिंक इज द रिब. Alright, so this is first. Can you guys understand this? This is first, this is second, this is third, this is fourth. Now, if you didn't understand that, ma'am, what are you doing? We are not understanding. Then the last resort is mark 4th posterior rib. Okay. So ideally, you should know everything कि कैसे करना है. At least you should know anterior, posterior. But if this also fails, then right 4th posterior. Because twice this question has come, both times it has been asked as right 4th posterior. Okay. So I've given you all levels of knowledge here. ठीक है. चलो. अब चलते into next one. Which of the following is MRI better than CT? MRI is the best for anything to do with nerves, है ना? So brain, spinal cord, nerves. So Pancoast tumor is a superior sulcus tumor which can involve the brachial plexus, which can involve the roots. So this is why MRI is better. Baki sub tumors, we have seen that anything to do with the lung, it is going to be CT, which is the best. So Pancoast tumor is the only one where MRI is better. Okay. All right. So this is what you have to know. All right. 25-year-old male with a pulsatile supraclavicular neck mass. What is the most appropriate next step? तो कोई भी आपके पास आ रहा है ऐसा pulsatile mass, तो मन तो बहुत करेगा कि नीडल डाल देते हैं, देखते हैं क्या निकलेगा. No, never do that. क्या निकलेगा? Blood ही निकलेगा, है ना? So never ever put a needle into it. So definitely this is contraindicated. What you have to do next is Doppler ultrasound. So anything pulsatile, we want to rule out an aneurysm, Doppler ultrasound is done next. Okay, this is what you have to do. Anything vascular, like in this case, if I tell you painful ulcer in a smoker male, क्या diagnosis बनाओगे? Medicine question होता तो? Smoker male, painful ulcer, very good. Thromboangitis obliterans, which is also called as Berger's disease or Berger's disease. What is the correct spelling? U, है ना? U आना चाहिए because U is V. साथ साथ होते हैं. So vasculitis. What is Berger's disease? This is IgA nephropathy, है ना? तो ये Berger किडनी का है, ये वाला Berger हमारा है. So thromboangitis obliterans is Berger's disease, which is seen in smokers who can have critical limb ischemia and gangrene. But either ways, अगर ये elderly male होता with gangrene also, anything vascular, first thing that you're gonna do is Doppler. ठीक है, ये हमें पता होना चाहिए. DMSA स्कैन हम किडनी में यूज करते हैं, न्यूक्लियर मेडिसिन स्कैन. सो ऑन दैट ट्रेन ओनली लेट्स स्टडी वन न्यूक्लियर मेडिसिन स्कैन. सो इफ आई आस्क यू पैराथायरॉयड एडेनोमा, what is the investigation of choice? Very good. Sestamibi scan. Now this sestamibi, we combine it with technetium. So this is technetium sestamibi. Wherever there is parathyroid adenoma, you will see this hotspot. Now recently what we do is we combine sestamibi with a CT. Can you see कि यहाँ पे bone white है? This is called as SPECT. So इसको क्या बोलते हैं? This is sestamibi SPECT. So if I ask you, बताओ better कौन है? Technetium sestamibi या sestamibi SPECT? स्पेक्ट इज बेटर ना, क्योंकि यहाँ पे मुझे 3D लोकलाइजेशन मिल गया है. आई कैन सी वेयर द पैराथायरॉयड एडेनोमा इज. सो दिस इज ऑल्सो सेस्टामीवी ओनली, बट स्पेक्ट इज अ 3D वे. इट इज लाइक सेइंग कि भाई ये एक्सरे हो गया न्यूक्लियर मेडिसिन का और ये सीटी हो गया. सो ऑब्वियसली सीटी इज ऑलवेज बेटर. सो अगर दोनों ऑप्शन है यू विल चूज स्पेक्ट, बट इफ स्पेक्ट इज नॉट देयर इन द ऑप्शन वी विल गो फॉर टेक्नीशियम सेस्टामीवी. अंडरस्टूड? बेसिकली सेस्टामीवी होना चाहिए वर्ड. I hope this is clear for parathyroid adenoma. What is this investigation? Where again I see CT in the background and then there is this hotspot everywhere. PET CT. So this is a PET CT. PET combined with a CT scan. What is the radioisotope I use for positron emission tomography? It is 18 FDG. तो ये positron emission है. तो मुझे कोई स्पेक्ट का फुल फॉर्म बता दो. Single dash emission computed tomography. Just tell me what is the P. Proton, photon, positron, polio. No, it is not polio. What is this? This is photon. Single photon emission computed tomography. है ना? तो ये photon है because this is gamma ray. This is emission of gamma rays here, whereas this is a positron emitter. Positron. What is a positron? It is a positive electron. ठीक है. So what happens? This 18 fluoride is gonna release this positron which will combine with electron to form gamma rays, and that is how we will detect ki okay, this is where the tumor is, this is where the positron is getting emitted from. All right, so this is what you have to remember for PET CT. Tell me a tumor which is false negative. It is, even though it is a tumor, it will not be detected on PET CT. Very good. It is typical carcinoid. Okay, so typical carcinoid, even though it's a malignancy, it is a very well differentiated tumor, so it will be negative. Matlab PET will be normal here. So this is typical carcinoid, not atypical carcinoid, typical carcinoid. Second last slide, what is inverse squallow has been asked like so many times. FMG is the only exam where you have short radiotherapy questions and those are always scoring questions. Yeah, all of this is for FMG, definitely. हाँ, ठीक है. पूरा खत्म होने के बाद ये दिमाग में ख्याल आया क्या ये मेरे लिए है. काफी जल्दी सवाल आया दिमाग में. सो इनवर्स स्क्वायर लॉ. ऑलराइट, सो दिस इज इनवर्स स्क्वायर लॉ. कि अभी तक सुनने में मजा आ रहा था, अब पूछ लेते क्या ये काम का है मैम हमारे लिए. आई हैव एग्जामिन्ड 19 days. शुड आई हैव हर्ड ऑल ऑफ दिस? या इट इज फॉर यू ओनली. सो इनवर्स स्क्वायर law. So intensity is inversely proportional to the square of the distance. Meaning if this is the source of radiation and I'm standing here at x distance, I will get I amount of intensity. But if I go to double और दूर चली जाती हूँ, मुझे कितना इंटेंसिटी मिलेगा अब? चलो मैथ्स करो. हाफ, 1/4, 1/9 और 1/12. गुड, 1/4. ओके, सो स्क्वायर हो जाएगा. डिस्टेंस जितना बढ़ाया उतना ही हो जाएगा. सो दिस इज इनवर्स स्क्वायर लॉ. ऑलराइट, ओके. नेक्स्ट, लास्ट टेबल, फटाफट. विच सेल टाइप इज, इसमें से एक क्वेश्चन गारंटीड, इफ नॉट मोर 2-3 क्वेश्चन कैन कम फ्रॉम दिस टेबल. ओके, सो ये बस करके जाओ एंड जिंदगी इज गोइंग टू बी वेरी सफल. Most sensitive cell type which is undifferentiated. Undifferentiated cells very radiosensitive. Something which divides a lot, rapidly dividing, is going to be very sensitive, whereas stuff like CNS, which is quiescent, है ना, neurons don't divide, very well differentiated, they will not be radio sensitive, they will not be radio sensitive. All right, so that is the basic concept. So इसी को translate करते हुए into organs. So organs like gonads, right, they have a lot of proliferation happening. So gonads are most sensitive organ. Is organ wise least sensitive is the vaginal epithelium because it's very well differentiated. Blood cell that is most sensitive is a lymphocyte because it has the largest nucleus, whereas a platelet, no nucleus, chotu sa, least sensitive. Cell cycle phase which is most sensitive, G2M, whereas S not sensitive. So S is sakt is how you can remember. So least sensitive. Tissue which is most sensitive, hematopoietic bone marrow, right? So hematopoietic or bone marrow is constantly producing blood cells, so that is why it is most sensitive. Whereas least sensitive is the brain, जहाँ पे neurons don't divide. Once damaged, they are not gonna divide. Structure of the eye, which is most sensitive, is the lens. That is why cataract is a side effect. Least sensitive is going to be sclera. Okay. Tumors में सारे याद मत रखो, one one if you remember which has been asked. So most sensitive you remember bone tumor, Ewing sarcoma, least sensitive osteosarcoma. वैसे I have given you Wilms and Homp, you can remember entire list, but वो सवाल आए नहीं है. Only these if you remember, it's good to go for the exam. Now let's talk about this. इसमें से बहुत questions आते हैं. So if let's say something like a Chernobyl accident happened, so much nuclear leakage has happened, what will be the order of the systems getting affected? So the first system to be affected is going to be the most sensitive one, which is hematopoietic, है ना? GI से पहले हो जाएगा hematopoietic syndrome. So hematopoietic syndrome will be affected when you have around 1 gray exposure. उसके बाद जाएगा GI, which is around 10 times higher radiation it will need. And then you have cerebrovascular, CNS and heart, which will require 10 times more, around 100 grays radiation it will need. But if I ask you कि भाई death सबकी होनी है इनमें, how soon will the symptoms happen? तो इसमें slow mauth, very painful slow mauth will happen, around weeks for the death. In GI it will take a few days for you to die, but if your heart and brain stop working, you're gonna die in a matter of hours. So the symptoms are quicker if you have higher radiation getting affected. Very logical. ये एक बार सुन लिया तो वापस नहीं रिवाइज करना पड़ेगा. All right, so this is it as far as radiology last minute revision was concerned. I have 4 minutes left. So in those 4 minutes, what I want to tell you all is now what you do for the rest of the 18 days is important, yes. But what is more important is the kind of attitude and the approach that you have. I want all of you to be very, very confident that whatever you have read over years, not just days, is there in your system. When you look at the 4 options, you trust your instinct, just mark what you think is the best. Few important things you have to remember: manage time well. Not having time to see questions is the most criminal mistake ever. That is unforgivable. So time management पहले से करना है. Last half an hour में time management नहीं करना. पहले से every half an hour check like your run rate is on track. You are doing 30 questions in this much time, so divide total question into total number of minutes and manage it accordingly. Very, very important. Second, you have to eliminate. You have already promised me, ma'am, 300 questions. A, B, C, D. My approach is going to be, this is unlikely, this is unlikely. Out of these two, which is better? That is how you have to approach every MCQ. No doubt, no anxiety during the exam. If you feel you don't know 5 questions in a row, it's okay. Happens to everybody. Maybe 6th question onwards, you're going to know everything. So everybody is going to have a rough patch in the exam. Your rough patch might be the first 5 questions. Don't let that affect you. Just keep telling yourself all is well. It's all going to be okay. So this is what you have to now ensure, that you are confident and you go in trusting and backing yourself. Okay, so all the best. I will post this PDF on the Telegram group so that you can revise. Even if the session is taken off YouTube, you can revise using the PDF, and for the others it will be there in the app for you to revise. Okay, so thank you so much and all the best. इसके अलावा we will also be having 3 BTR sessions. It's not the last time we are meeting. Date I have forgotten. I think 12, 13, 14 are the 3 dates where we have. Let me just check. हाँ 12, 13, 14, so 2 to 3 आवर्स के सेशंस लेंगे वैसे ही. तो जैसे अभी हमने रेडियो रिवाइज करा, नो 13, 14, 15. ओके, द डेट्स आर 13, 14, 15. 3 BTR सेशंस समटाइम इन द इवनिंग वील कीप दीज सेशंस. फटाफट फटाफट तब तक ट्राई करो, 13 तक सारा कुछ रिवाइज करो, सो दैट टाइम इट्स एक्टिव रिकॉल, एवरीथिंग गेट्स कंसोलिडेटेड and you take a lot of confidence out of it. Okay, so that's what I want कि तब तक रिवाइज कर लो ताकि उसके बाद आपको सिर्फ BTR रिवाइज करना है very very quickly. Okay, so ये होगा. Non-visualization of gallbladder is acute cholecystitis. Any other specific questions you have, you can ask now or you can ask in the group also. Acute cholecystitis में HIDA scan में non-visualization होगा. No, no, this will obviously not be like offline BTR, which was, it was 12 hours, or like this is 2 hours. So this will be the essence of it. So you can still come, if even if you've attended offline, you haven't done online, still attend these classes क्योंकि काम होगा, एक रिवाइज हो जाएगा है ना साथ में. So this is what you have to do. Okay. All right. Okay. Thank you so much. And nothing much. I think इतना कर लो बहुत है. Radio isotopes and all you can skip. Just do the previous year question. So अभी how to approach this marathon is attend the classes, उनके PYQs कर लो. So suppose आज दिन में pharma, radio and peds है. Make sure before tomorrow you do all of the PYQs. तो इन subjects का closure करते जाओ साथ साथ. Don't just see the classes. Keep closing these subjects off, all right, so that by the time 13th comes, now you have to consolidate everything, revise everything, and it'll be done. Iodine numbers में ना just दो चीजें याद रखो अदिति. Iodine 123 is what I use for my scan, radio iodine scan. Iodine 131 is what we use for treatment because it emits beta rays and gamma rays both, so it is what we use for radiotherapy. Those के questions नहीं आते. आजकल तो क्लिनिकल क्वेश्चंस ही आते हैं, मेनली इमेज बेस्ड, दैट वी हैव डन. आयोडीन 125 इज समथिंग दैट इज यूज्ड फॉर ब्रैकीथेरेपी. ओके, ब्रैकीथेरेपी में यूज करते हैं ये वाला. ठीक है, दिस वन इज यूज्ड फॉर सिस्टमिक रेडियोथेरेपी. ओरली देते हैं या आईवी देते हैं, इट विल गो एंड बाइंड टू द ट्यूमर. All right. Okay, guys. So thank you so much. Take a break and then you will have pediatrics in I think 1 hour. So thank you so much and all the best and I'll see you all soon. Bye.